Thank you very much for the invitation to come and speak to you. My name is Ben MacArthur. I'm a professor in the Faculty of Medicine and in Mathematical Sciences at the University of Southampton. I'm really interested in understanding healthcare data and biomedical data. I'm going to tell you a little bit today about how health data analytics might help you. So let me start by saying, well, what is data? So data can take many different forms. So you might get, for example, a series of scans. These are images, or they could be movies even. You might have genomic data, so a genome sequence for an individual. You might have some records, so prescriptions or even handwritten clinical notes. You might have data which is collected, for example, from an activity monitor. This is a bike ride that I did using this app, Strava. You collect a stream of data about what the person is doing. You could have a device or some kind of technology that's monitoring an individual's physiology in some way. And increasingly, you'll get large data sets which are electronic healthcare records. So all of these are different kinds of data, and essentially, data can come in many different forms. For the purposes of analysis, a data set is really just a set of numbers. So that's what data is, and this is what data is not. So data is not in itself useful. If you have a lot of data, it's not necessarily going to do anything for you. It's like owning a gold mine, but not having any tools for extracting the gold from the ground. Data does not necessarily provide an increase in knowledge or understanding. If you have the wrong data set, it won't inform the technology that you're developing. And one point which is important, which is that more data is not necessarily better. Collecting more and more information is not usually the best strategy. It's like trying to find a needle in a haystack and just adding more and more hay to the haystack at the same time. The task really is to strip off all the data that's not useful to you and focus on the data that is useful to you. So deriving benefit from data requires methods to store that data, to process it, and then methods to extract insight from it. And that's really what I'm interested in. So there are really three aspects to what we would call data science. The first one is data organization. So if you have some data that you're collecting about your technology, you have to arrange it into a coherent structure so that it can be interrogated effectively. So that's the first stage of data analytics. The second part is really developing methods from statistics and machine learning, and I'll mention a little bit about what I mean by machine learning, to extract actionable information from the data. So can I take that structured data set and learn something from it in such a way that I can do something? And then the final part is really presenting what you found to all of the stakeholders. So can you present the results in the right way to the right people? So machine learning is a whole class or a whole cluster of methods that are very popular and growing in importance. This is the definition that I give my students in class. Machine learning is the study of algorithms that enable computers to perform specific tasks without specific instructions, but instead using data to infer statistical patterns. So for example, these are images of different types of skin lesions, and some of them are benign and some of them are cancerous. And you could develop an algorithm to distinguish between benign lesions and malignant lesions by consulting a clinician and asking them to give you a set of rules. Rule number one, what colour is it? Is it a dark colour or is it a light colour? Rule number two, does it have a rough boundary or a smooth boundary? So you ask the clinician to give you specific rules. That's not what machine learning does. What machine learning does is it takes the data in the form of a set of images that have been annotated in some way. So a clinician will mark to say this one is malignant, this one's malignant, this one is benign, and so forth. And then the machine learning algorithm learns the patterns in the data that are predictive of either malignancy or a benign lesion. So the idea is to not impose upon the data some information that you have, but to learn from the data itself. So essentially, modern machine learning methods are able to learn complicated patterns in data and then make predictions based upon those patterns. The key thing really is that if you want to generate some kind of insight or understanding about your technology, it's really the combination of well-structured data plus the appropriate analysis. And if you have those two pieces together, then you can generate unprecedented insight. So I'm going to tell you, what I'll do is I'll give you a very short example of the kind of thing that we can do with some data. And it's a very high level example because I don't have much time. And it's to do with NHS Digital data. So the NHS Digital have what is called the Hospital Episode Statistics Database. And it contains information, highly processed information, about all admissions, outpatient appointments and A&E attendances at all NHS hospitals in England. So this is a very, very well structured data set. Everything is mapped onto consistent codes and everything is monitored and curated and highly curated. Now this data can be used to better understand different patterns of diagnosis in treatment, potentially how they vary across the country, and understand the needs facing the NHS with respect to certain diagnoses. So you can take this as a way of understanding how the NHS is currently functioning with respect to certain diagnoses or certain treatments. So I'm going to give you an example. All of this data came from Device Access. They have a license for this HES data set. It's a rather arduous process to get the license, but once you have it, it's an enormously rich data set. And I'm going to tell you a little bit about some of the analysis that we have done. So I'll focus in on a very specific issue, which is to do with our region. So I got from the HES data set for Southampton General Hospital for last year. So every single admission at Southampton General last year, there were about 200,000 episodes, so 200,000 admissions. Of course, there were less patients than that, because some people go in multiple times in a given year. There are about 100,000 patients. Now the interesting thing, just to start off with at a very high level, is that there's a very large number of diagnoses being made at the hospital. Over 7,500 unique diagnoses being made, and 4,500 unique interventions. So these are unique OPCS codes. And in total, these 200,000 patients spent 471,000 approximately days in hospital. One of the important things to say is that this data set is really very big. Just for Southampton General, there's about 60 million data points for last year. So if you scale that up to the country, there's about 200 NHS hospitals, and actually we have data for some private providers as well. It's an enormously rich data set. So once you have that data, you can survey what's happening. So at Southampton General, this is the list of the most common procedures. This transthoracic echocardiography is a scan of the heart. This is a very common procedure. In total, people that came in and were given this procedure spent about 28,000 days in hospital in total, in that one hospital. What you notice actually is that lots of the top procedures are all exploratory procedures, so they're scans of some kind or another. And then there are some very, very generic procedures in there as well. So you can survey what's happening. If you look into any of these diagnoses, you'll find that they're hiding a lot of interesting information. So for transthoracic echocardiography, there was about 700 different reasons why people came in to have that scan, so 700 primary diagnoses. But you can delve into the data a little bit further, so you can see, well, how long did they stay in hospital? How many other diagnoses did they have? How old were they? How many episodes were there, and so forth. So you can start to dissect the data down and break it into pieces. And it tells you more and more about the different patient cohorts that were coming into the hospital for this purpose. What happens to secondary diagnosis? So when the patient comes into hospital, the admission is logged onto the database, and they are given a primary diagnosis. So in addition to a primary diagnosis, which is the main reason why they've been admitted, they're also given a whole load of secondary diagnoses. So these are other things which were noted on their records. And so these are the top secondary diagnoses. So the most common thing to be logged as a secondary diagnosis was hypertension, because lots of people will come in and it will be noted on their records that they had hypertension. Drug allergy, of course, type 2 diabetes, and there's various other ones, allergy to penicillin. This is interesting to me. Psychoactive substance abuse is a very high one. I wouldn't have expected that. Now what you find is that these secondary diagnoses also have an effect on what happens to the patient. So for example, if you look at, this is just two examples. On the plot on the left is how long the person stayed in hospital if they didn't have acute kidney failure. Acute kidney failure was one of these. It happens to be the 7th most common. This is how long on average they stay if they have acute kidney failure, and this is how long on average they stay if they don't have acute kidney failure on the horizontal axis, and if they do have acute kidney failure on the vertical axis. And each dot is a unique primary diagnosis. So what you find is kind of what you might expect, that if they come into hospital and they get acute kidney failure along the way, they spend a lot more time in hospital. All of these dots are above this line, which is the y equals x line. So it's a very clear message for acute kidney failure. For something like type 2 diabetes, it's a bit more messy because some people, it doesn't really affect their length of stay, for example, but that they happen to have it as a secondary diagnosis. But what you can do is you can start to break down, these are the cohorts of patients that came in with for a certain treatment. These are the reasons why they were there. These are the secondary reasons, the secondary diagnoses that they had. Now, as soon as you do that, you kind of realise that there are some things hidden away. You can estimate how much it's costing the hospital as a secondary diagnosis. So, for example, the cost of acute kidney failure as a secondary diagnosis to the hospital in bed days is almost 60,000 bed days. Well, if you add up these top 10, they add up to about 150,000 bed days, which is approximately a third of the yearly resource in terms of beds at the hospital. So there are things hidden away behind the scenes that are very costly to the hospital that are not immediately apparent. But if you have the right data, you can start to extract those patterns and learn from them and quantify how much these things are costing. And importantly, it's a relative cost. So if I say that psychoactive substance abuse as a secondary diagnosis costs 1,000 bed days, I know actually that that's a lot less than acute kidney failure. So I can quantify things with respect to other things. So I can say, how costly is this? Not just as an individual diagnosis, but in context. The final thing, which is what I'm really interested in, and not many people have done much with, is that you can do this machine learning from the HES data set. So if we go back to that image of predicting skin lesions, benign or not, that was a machine learning problem. Well, you can do the same kind of thing with the HES data set. So for example, on the Southampton data, if you take in all of the patients that came into the hospital, what was their primary diagnosis, what was their secondary diagnosis, how old were they, what was their sex, what was their ethnicity, and all of those other factors, well, you can quite accurately predict their length of stay from the HES data set. And you can do similar things for secondary diagnoses. So, for example, you can predict the risk of getting a pressure ulcer, or the risk of having an acute kidney injury, or the risk of having delirium, which is what we did for Prolera. Now, so what that says is that there's a lot of information hidden away in this data set that is not being fully used. And with the right methods, you can learn a lot from it. The one thing I would say is that the HES data set is very well curated, but it's kind of coarse or high level. And by that I mean it has some information about the patients, but not very much information about them. So if you are also collecting complementary data concerning your technology, which is more detailed, then that can be incorporated alongside the HES data set to get a much better feeling for how best to stratify the patients, for example. So I want to summarise by saying this was the correct question I was asked to address. How can data analytics help you? Well, the first thing to say is that to be of most use, the data must be very carefully collected and collated. You can't make sense, or it's very hard to make sense of unstructured, random data. More data is not necessarily better, it just makes the problems harder. It's the right data that matters. And then really there are 3 levels of things that you can do with data. So the first thing is that you can use the data to determine or better quantify the need for your technology. So one of the things you can do with data is that you might have a feeling or a hunch or an intuition that this is an important problem, but the data will tell you exactly how much of a problem it is. So you can quantify things exactly. The second thing that you can do is that once you have enough data, you can start to stratify the patients. So for example, you can stratify them into patient subgroups that will most benefit from your technology. And then finally, if you can do these things, then you can start to think about how the data will help you to refine treatment pathways and provide more personalised treatments. So the main message I want to get across is that data can be very, very powerful, but you have to collect it in the right way and you have to develop the right tools to understand it. So I'll finish there. I should say that I work for the University of Southampton, the Institute for Life Sciences. I'm also a fellow of the Alan Turing Institute, which is the UK Centre for Data Science and Artificial Intelligence, and there's an awful lot of experience there on healthcare data analytics, and all of the data came from device access.